Hi, my name is Bart Willems. I'm in a joint appointment between the Western Cape Government Health, where I'm involved in quality assurance, and Stellenbosch University, where I'm involved in teaching and research. And this is a presentation I prepared for the Private Public Health Forum that happened at Lentegeur Hospital on the 27th of September 2016. Overview of the presentation. I'll talk a bit about quality concepts like universal coverage, and then I'll speak about what I learned at the International Forum on Quality and Safety. Then I'll speak swiftly about quality improvement initiatives in the Western Cape Government Health, followed by developments in teaching and learning at Stellenbosch University. Our Minister of Health, Minister Motsoaledi, said that South African healthcare system fails to provide quality care for the majority of its citizens. And different people have different arguments regarding this, but to a great extent what he said is true. 50% of South Africa's health budget is spent on 60% of the population in the private healthcare services, and the rest, the other 50% approximately, is spent on about 84% of the citizens. So you can think that there's different tiers in the healthcare system, and there's inequality and inequity in health spending in the country. In the Western Cape government, we often hear that we have to work smarter, not harder. This clever guy said, if you always do what you always did, you'll always get what you always got. And I think in a healthcare system where we've always been doing what we've been doing, it's difficult to change, and it's difficult to change results. We work in a system where healthcare workers have to train for anything from 3 to 15 years, and they learn clinical knowledge, but at the same time they also learn how to fit into and adapt to the current system. So then when you ask them to do things differently to get different results, they find it difficult and confusing. So my argument is that quality improvement is a way to assist people and give them a framework of how to think and work differently. This was published in The Lancet in 2008. It's a little bit old, but I think still relevant. That shows life expectancy compared to gross national income per person. And if you look at the trend over the world in the countries that was used, in general life expectancy goes up as country income or spending per person goes up. You can see that South Africa down here is completely out of the trend, and then you get other countries that perform better than we expect, and Cuba and Vietnam are examples. So in this graph you can see that for the amount of money we have to spend per person in South Africa, the life expectancy is much lower than we could achieve for the amount we spend, and therefore we can say that the funding spent on health is spent inequitably or unfairly. The source of this slide is Prof. Di McIntyre from the University of Cape Town, and this looks at different ways in which healthcare can be funded. You get mandatory prepayment, which is blue, voluntary prepayment, which is the red part, and out-of-pocket payments. Mandatory prepayment normally comes from the fiscus. It is paid through tax. Voluntary prepayment normally comes through medical aid contributions, and out-of-pocket is like paying as you go for healthcare services. And you can see when we compare South Africa's spending to many of the other countries in the world, our voluntary prepayment forms a much larger proportion of our healthcare funding than other countries. The only other country that's close to us is the United States. And in general, the funding spent for the voluntary prepayment funding spent on healthcare is spent on the private healthcare services. So that's one of the reasons for the inequitable spending in the country, and some argue that's one of the main reasons for the different health outcomes. Another concept that I'd like to convey is universal coverage. Universal healthcare usually refers to a health system which provides healthcare or essential healthcare services and financial protections to all citizens of that country or that region. In essence, it means health for all, and it's been implemented with various degrees of success in many countries around the world. When looking at universal coverage, it can be expressed as a cube, and we're trying to fill the cube. This axis is the population who is covered by the healthcare services, and of course we want to try to cover the whole population. This axis or side is the services, or the proportion of essential services that is covered by universal coverage. Of course we want all the essential services to be covered. And then the proportion of cost that is covered by universal coverage. And we'd like the total cost to be covered by universal coverage. Of course, this is ideal and maybe an ideological goal, but it has to be adapted for the context of each country or region. So in South Africa, as we're thinking about more equitable spending, so we can get more bang for our buck and move South Africa from the position where we are now in that correlation of GNI compared to life expectancy. There are different modalities that we're thinking about in South Africa. The one is national health insurance, and then other initiatives like the National Core Standards and Ideal Clinic. And this is our response to try to achieve national or universal coverage. At the same time, in South Africa, we've got a changing context. We've got a growing population, in-migration and population growth, of course. We've got a changing burden of disease if you look at the demographic transition from a phase 1 and 2 to more phase 3 and 4. We've got stagnant economic growth, which always makes everything a little bit more difficult. And then we've got tremendous inequity and inequality in the country. What we must remember is that most of the health interventions or the changes that we want to make has a direct effect or bearing on the frontline healthcare worker. And they're the ones who feel that they've been doing things in the same good way for a long time. And by adding more services and more work to them can be very challenging and demotivating. So whenever a change is made in the healthcare system, you have to keep in mind what effect it might have on the already overburdened frontline health staff. Looking at frameworks for health systems, Donna Bedian gave us this interesting framework looking at the structure, the process, the outcome, and the impact. The structure has to do with the healthcare facilities, and the healthcare workers, and the physical things that you put in place. The process has to do with the actions and the way in which these structural components work together, synergistically or not. The outcome is what we're trying to achieve with a healthcare system. Improve health outcomes, reduce surgical site infection, better control of diabetes and hypertension, reduction in body mass index. And the impact that we're looking to achieve in a healthcare system is longer lives for people in the country, a more productive country. And taking into mind the Donna Bedian framework and comparing that where the National Core Standards and Ideal Clinic, it is seen that Ideal Clinic and National Core Standards are heavily weighted in the structure and process components of the Donna Bedian framework. And they speak less about health outcomes and the impact it might have. And that might have to do with the current developmental state in South Africa, that we are trying to improve our structure and our processes with the idea that it will later on impact our outcomes and our impact in the healthcare services. But I feel that we should, as a country, express much better the outcome and the impact we expect our health system to have. And I feel that is neglected in the national core standards and the ideal clinic. Then looking at quality of care, the National Department of Health said it's getting the best possible results within the available resources. And everywhere in the world where they've improved healthcare system quality, they've been able to improve health outcomes. Whether it's a well-resourced first world country or whether it's a poorly resourced African country, if you focus on quality, you can improve health outcomes without increasing cost. And quality is a good way, therefore, for improving efficiency and effectivity of a healthcare system. Looking at quality in a little bit more detail, we want to try to define quality. What is quality and what is quality outcomes for a healthcare system? Then we have to measure the quality, and then of course we have to improve the quality. And those are kind of the steps when thinking about quality in the healthcare system. And then dimensions of quality is accessibility, acceptability, effectiveness, efficiency, equitability, and safety. In the Western Cape, we've developed a document called the Healthcare 2030, which is the long-term goal or the road to wellness in the Western Cape. And quality has been defined as customer perception quality, which links to waiting times, cleanliness, and staff attitudes. Clinical quality, which is measured with audits, surveillance, and surveys, looking at the preventative efforts, diagnosis, treatment, rehab, follow-up, and of course adverse incidents. And then caring for the carer. We have to think about our healthcare workers, and by caring for them, you create the right environment and the right type of workforce attitude that will improve the customer perception quality and clinical quality in our services. The current situation in the Western Cape, we have a huge organization with more than 30,000 employees, and I'd say it's a bureaucratic organization with an aging staff cadre. And we have to work in this changing environment, and therefore we have to adapt. And if we don't adapt, who knows what will happen. Different ways of changing or adapting is to change in big leaps or making big innovations like developing new treatments, building new facilities, discovering new devices. But it's not always possible to wait for these grand innovations to improve. It's very important to make small, incremental, continuous improvements because these can have a very big effect over time. What they also cause is a thinking, learning, and engaged and adaptive workforce. And if people are able to change on a small scale in an incremental manner, they will also be much better at adapting to these other bigger innovations when they do become available. And in my opinion, quality improvement is a very good way for healthcare staff members to become thinking, learning, engaged, and adaptive. Now I'll go to some of the learning from the International Forum on Quality and Safety in Healthcare, which I was fortunate enough to attend because of a prize awarded, and that happened in Gothenburg, Sweden in April 2016. 3,500 participants from all over the world came to talk about quality and safety in healthcare, and there was a tremendous amount to learn, and I'm just going to touch on the most profound learning for myself. First is the Swedish way. Olivia Wigsell, who is the Director General of the Socialstyrelsen, the National Board for Health and Welfare in Sweden, spoke about their cornerstones of improving health. First one was having the public health approach, taking and looking at health in the population level. And I found a big discrepancy or difference between the way that Sweden looks at their population's health and that of the American hospitals who presented at this conference at the same time. The American hospitals think about activities and impact within the hospital, and one of the main things they keep in mind at all times is cost. While in Sweden, they look at the whole population, not only the people attending the services. So they've got a much broader, much more comprehensive look at health. So the cornerstones of the Swedish way is a public health approach, not a hospital-centered approach. They focus on trust, and very interesting, there's a big harmony between the government in Sweden and the citizens. And health is a public matter in Sweden, and therefore the citizens feel that the state may interfere in health. They find it acceptable. And there's a great harmony in the way that the citizens and the state thinks about health services and health outcomes. An example that was given was if the Swedish Department of Health decides that it is important that children who cycle wear bicycle helmets, the Swedish people will sit back, think about it a bit, and say, well, we trust these guys, they're the experts, they probably thought it through, and even though we'll have to spend money to buy the helmets, we believe that the helmets would have a benefit for our children, and we'll do as the Department of Health advises. On the other side, in the American society, if the state would recommend that children wear bicycle helmets, the parents would jump up and down. They would feel annoyed that the nanny state is telling them what they have to do, and they will freak out that the government is taking away the freedom of their children. So the second cornerstone in the Swedish way of rendering health services is trust between the service provider and the client. In this case, the government and the people, the citizens. And the third one is to measure the quality of the healthcare services and measure outcomes of the quality of the healthcare services. So they use the Swedish quality registers. They were initiated in 1970, and there are more than 100 registers, each focusing on a specific disease. And the registers include medical results, processes, and client perceived quality. And they are contributed to by everyone rendering healthcare. They use population-wide information on health and healthcare. An example is the cervical cancer register, where they look not only at surgical immunizations for surgical cancer, but they look at the services rendered, the number of people who actually need the service at a certain time, taking the population into account, what proportion of these people receive the services, and they also look at the mortality because of cervical cancer on a population level. Interesting enough, they can use the data for research, and there's a lot of information on data linkage. They can also use the data to improve the services. Another interesting fact, she stated, is that quality improvement is an everlasting endeavor. It's not something that you do for a month or a year. Quality can always improve, and if you don't focus on quality, it can always decrease. So quality improvement is everlasting, and it's something that never stops. How do they do it in Sweden? How do they do quality improvement? They make sure that all data that is collected is transparent, and this is shared with clients, patients, and those involved in the healthcare services. It is shared healthcare outcome data. They use knowledge for action, so they use the data that they collect and they use evidence to improve their services, and it is person-centered, so it's heavily focused on partnerships between the clients and the service providers and co-production of plans. I think that's something we really need to work on in South Africa. That's it from the Swedish way. Now we get to a different concept that I learned that was brought to my attention by Roland Heifetz. It has to do with technical problems and adaptive challenges. And he said the biggest single failure of leadership is to treat adaptive challenges like technical problems. In this table, I'll show you the differences he explained between technical challenges and adaptive challenges. Technical challenges are generally easy to identify, often lend themselves to quick and easy solutions, often can be solved by an authority or an expert, require change in one or a few places. People are generally receptive to technical solutions, and solutions can be implemented quickly. And adaptive challenges, they are more difficult to identify and they are very easy to deny. They require changes in values, beliefs, roles, and relationships, and approaches to work. People with this type of problem generally struggle to learn how to solve it. And to solve it, you have to learn. There must be new learning and development. It requires change often in numerous places, and people often resist this change. And there is this that adaptive challenges is necessary. And solutions requires experiments, discoveries, and they can take a long time to think up and implement. And he said also, for quality improvement, we don't only need subject matter knowledge, but we need clinical knowledge. And it's come to my attention that in our medical education, health science education, nursing, dentistry, medicine, we focus heavily on subject matter knowledge, and we often neglect the systems knowledge. And that's often why many of our healthcare facilities are in the state that they are, because we only focus on the clinical subject matter knowledge, and no one is studying or trying to improve, or very few people are studying or trying to improve the system. And how do we normally handle and manage adapt to change? For technical solutions, it's good to write a policy or a training or a program or application. For adaptive solutions, it's more difficult. You have to stimulate thinking and inquisitiveness. There has to be internalization of the problem for learning and understanding to take place. Lots of sharing, and then building and co-creation should happen. That causes change and adaptation over time. And one of the big problems that we have is we have adaptive solutions, and we try to solve them with technical solutions like a program or an application, a training or a policy that will fix everything. But we really have to engage our staff to come up with their own adaptive solutions over time to solve the adaptive problems. Just a couple of quotes from the forum. Almost all quality improvement comes via simplification of design, layout, processes and procedures. A profound one was that all of us have to do our job every day, and we have to do our job better every day. Great care is discovered, not decided. Improve quality and you'll automatically improve productivity. It's not enough to do your best. You must know what to do and then do your best. So that has to do with how do you decide what is good quality and then. And the staff have a duty and the right to see both the cost drivers and the effectiveness and outcome measures, and so do clients. And only then can we have a combined understanding and a goal of what value we want to strive to. So we have to understand our value and compare the cost and the effectiveness to understand how we can achieve value. Then, of course, the people. In health systems that are performing well, they have people who want to do better and serve the client. They have people that learn from their mistakes. They have leaders and managers who create a non-punitive or safe psychological space for employees to work in. They have engaged and eager workers that are interested to improve. And often, this brings back the fun or fulfillment at work. And it's important to challenge workers or employees, but to such an extent where they still feel in control. There must be a balance between a boring work environment and an over-challenging work environment. And it is said that quality improvement is a way to switch on many of these characteristics of a well-functioning workforce. And the fantastic thing is that quality improvement skills can be taught, and it uses an iterative approach. So it's not difficult to install that in a workforce. And once people have this unified approach or a unified language, they are much better at competing and sharing and discussing and learning together, to improve the healthcare services. The picture at the top is just of a boy who built a bicycle and it didn't work. And the whole idea is that he shouldn't be punished, he should be rewarded for trying, and together with others he should learn and see how he can improve that tricycle. He shouldn't stop now. He's come a very long way. When we look at the diffusion of innovations into an organization or into a society, you get different steps. This is a well-known graph. First you get the innovators, which is about 2.5 to 3%, then the early adopters, then the early majority, late majority, and the laggards. It doesn't mean that the same people are the innovators for every type of change. So some people might adopt better to technologies and others might adopt better to other new innovations. So there are different innovators for different types of changes that are introduced. And very important, at the Quality Summit, they spoke about the difference between a troublemaker and a rebel. Troublemakers are those people who whine, who are not engaged and are not really interested in making an improvement in the system. They are more interested in making improvements for themselves. While the rebels are the people who might be whining and pushing, but the reason why they do that is they've got a cause, and their cause is often to improve the system or improve the client satisfaction. And for leaders or managers, it's very important to differentiate between the troublemakers and the rebels, and try to identify the rebels, work with them and support them, because they're the ones who are often the innovators and the early adopters who can bring about change. It's said that if around about 10% of the population eagerly supports a new idea, that idea will probably take over. So often you only need just more than 10% of the employees to think or take up a new idea before everyone else will jump in. It's also very important to celebrate successes and the small wins, and to showcase and share successes that the early adopters and the innovators have made with the early majority and the late majority, to make them see the benefit. And then they also said no crisis should go to waste. So it's very important to utilize urgency. Which brings me to this: adaptive tools and quality improvement tools and an adaptive approach can lead to sustained improvement. And then a couple of other good quotes. In times of change, learners inherit the earth, while the learned find themselves beautifully equipped to deal with the world that no longer exists. Leaders are the signal generators who can reduce uncertainty and ambiguity about what is important and how to act. Do what you say you'll do, says Gary Kaplan from Virginia Mason Medical Center. Silver Grace, this is a Dutch medical funder, and they have moved away from funding processes like diagnoses, treatments, and operations to outcome financing, which I think is a breakthrough in healthcare financing, and I think in South Africa we can learn a lot from that. Currently in South Africa, the private healthcare services and the private healthcare funders get their income from doing things and doing processes, and not so much funded for advancing health outcomes or improving health outcomes. I think we can learn from that. And the other thing this organization, Silver Grace, said is that there's a big difference between quality assurance and quality improvement. Quality improvement is much more effective because it can shift the mean, or it can improve the mean. When you look at quality assurance, often we take into account that there's a cutoff line, and people who perform below this cutoff, they get attention and action is taken here, which means only this small proportion of healthcare facilities will improve their services. They might move from this area to here, but it will do very little to the mean. that is quality assurance, because the big proportion, the gross, the majority are satisfied with the way they do things and they don't try to improve. When you look at this graph on the other hand and you take into account quality improvement, it has, similar to the Jeffrey Rose article on improving the health of populations, you don't only take action on the ones below the threshold, you ask everyone to try to improve their health outcomes or they improve their services. And that causes a situation where the whole graph moves to the right and you can change the mean and you can function at a whole different level. And the idea is that in the long run you can move further and further towards the improved area. Looking at quality in the Western Cape Government Health, we've got a few quality improvement initiatives running, but I'd like to just point out that the one that's functioning best at the moment is the Best Care Always initiative. That is a initiative in which hospital-acquired infection is reduced by implementing evidence-based care bundles to reduce surgical site infection, catheter-associated urinary tract infection, central line bloodstream infection, and ventilator-assisted pneumonia. They use the quality improvement approach to implement, and very importantly, data forms a critical element of this, and especially data measured over time after improvements or changes were implemented. The quality improvement is used for the Best Care Always initiatives, but it can also be used to and applied to antibiotic stewardship, waiting times, occupational health, and so on in the province. I think quality improvement can be used to improve pretty much everything within the Western Cape Department of Health. Then we come to just some success stories with the Best Care Always initiative. In Grooteskier, in one ward, they reduced catheter-associated urinary tract infections from 9 per 1,000 catheter days to 0. At Western Cape Rehab Centre, they below 1 infection per 1,000 catheter days. In certain wards in Parel, Grooteskier and Tygerberg, they reduced their central line infections per 1,000 days to 0. Ventilator-assisted pneumonia has reduced tremendously in Grooteskier and Tygerberg in the intensive care units where they have implemented the ventilator-assisted pneumonia bundles. In Paarl, they went to about 174 days between septic cesarean sections at a stage. And the one close to my heart is at Mowbray Maternity Hospital, where the surgical site infection was about 3% before the bundles were implemented, and they could reduce it to about 0.5%. And just keeping in mind that if the hospital would do about 300 cesarean sections a month, initially about 9 of these patients would have severe surgical site infection and would cause them to be readmitted to Grooteskier Hospital, where they would have to stay in hospital for extended periods of time, receive antibiotics, and often have relux surgeries or even hysterectomies. You can think of the cost to the healthcare system and also the inconvenience to the patient and the reduction in client satisfaction, especially in an area where healthcare services should first do no harm. Surgical site infections really contribute negatively to the goals of the healthcare system. So the reduction in surgical site infection from 3 to 0.5% in Mowbray Maternity Hospital not only saved cost, but it definitely increased client satisfaction. Looking at waiting times, at Worcester and TC Newman Hospital, they used quality improvement to greatly reduce waiting times and implemented appointment systems. And a lot of these innovations were showcased at the Quality Summit that was hosted in Cape Town in 2014. And some of the speakers were invited to the International Forum on Summit on Quality and Safety in Gothenburg, Sweden. So I think we've come a long way in the Western Cape Department of Health. We've shown that quality improvement can have an impact, and I'm hoping that we'll use this methodology to further improve health outcomes in the department. Looking at quality improvement in the undergraduate curriculum, we did a curriculum review and we asked young doctors who just qualified from Stellenbosch University what would they need to better perform as doctors in the current context in the South African healthcare system. And they said they're fine with clinical knowledge, they know what to do, they know which medicines to prescribe, they know how to diagnose, but they get stuck when things out of their control inhibit them from practicing the good clinical medicine they learned. Things like they run out of medicines, they run out of gloves, theatre staff take very long to turn around the sterilization of equipment, and then they can't practice the excellent clinical medicine that they've learned. So we've decided to include quality improvement in the undergraduate medical curriculum, and in their 4th and 5th year they learn about quality improvement in the doctor as change agent module, and in their final year then they have to do in a healthcare services in the real life environment a quality improvement project with at least 2 PDSA cycles. And many of the students have done fantastic work, and if you're interested to know or learn more about the work that the students have done, please get in touch with me. I'm happy to share. Rob Bethune from the Southwest Academic Health Science Network in England said, when he introduced quality improvement for young doctors and trainees, he said that success is important for future success. So success breeds success, because when students or young doctors or anyone who starts off with quality improvement are successful, their attitude towards quality improvement changes. And this Tom Downs said, he's from the Sheffield Teaching Hospital, interdisciplinary teams are critical, because the more people you involve from more different interesting backgrounds, the better ideas you can come up with, and that makes people work much better together as teams. We also started a postgraduate quality improvement course, and it's a module in the postgraduate diploma in health management. It's a short course of 3 days, mainly run by Fezene Baruzi and Christelle Nesselman, who both have extensive experience in quality improvement. And this is entertaining, interactive, and based on adult learning principles. And when I joined this course, I saw that students contributed because of their background and their knowledge, and they were happy to participate, and I think they learned a lot. And of course, you're welcome to join this course. We run it again shortly. If you're interested to also send other people or staff members to the course, please do so. How do we spread quality improvement to the Western Cape government in the future? We've seen that students arrive now with this new quality improvement knowledge in an environment where other people don't understand where they come from when they speak about quality improvement. So we have to change the services. We started working with the family physicians, and they requested a training, so we did a basic introduction to quality improvement for them on the 3rd of May. But my question is, how do we spread this approach even further, and how do we spread this type of thinking even wider in the Department of Health and also in private healthcare facilities? Because we've got a lot of other challenges like national core standards, ideal clinics, waiting times, adverse incidents. And we have to get staff to engage around these methods, and my opinion is that they can use quality improvement to engage and improve. There's also questions whether quality improvement can be linked to the care club. So I'm hoping that between government, industry, universities, staff members, and also clients or patients, we can come together to form a type of greenhouse for quality improvement, where ideas are nurtured and supported and shared, and where we can all work together to make quality improvement a standard practice in the Department of Health and in other healthcare services in the Western Cape. And I think there's a lot that we can learn and share between industry, private and public healthcare services. So my take-home messages: quality improvement efforts can be large or small, simple or complex, and involve a few or many people. Regardless of the size and complexity of the improvement effort, the principles, strategies and steps remain the same. Quality improvement can improve health processes and health outcomes in any context, whether it's rich or poor. And the steps of defining, measuring, learning and improving and sharing is very important for all healthcare service providers to learn. In healthcare, people are at the core. The whole system is driven by people. It relies heavily on human-to-human interaction in the Department of Health and in health services. And therefore we have to invest in our people to make them inquisitive and make them excited and make them engaged again to improve healthcare. I think there are many trailblazers internationally who we could learn from. Think about the examples in Sweden, the UK and the United States, but many others in the world. And I think if we can utilize their learning and invite them to come help us to get quality improvement going on a large scale in the Western Cape, I think many of them would love to contribute and learn from our context and environment. So let's reach out and get the trailblazers to join us and assist us in the Western Cape. Thank you very much.